Good morning, everyone. This is Richard Afable, and I want to welcome each one of you to this session of special speaker session for the Center for Healthcare Management and Policy of the Mirage Business School. And again, a deep and grateful welcome to each one of you for participating. Our special session today is entitled COVID-19 Challenges, Solutions, and the Future. And we have a tremendous panel of speakers who will share their insights and their experiences in their organizations and in their healthcare communities as to the effect of COVID-19 and the challenges that have come upon themselves personally as well as their organizations. And I think that this will be a very, very beneficial and useful session for each and every one of us. Again, thank you for joining us today. I have been an advisor to the Center for Healthcare Management and Policy for going on 2 decades now. It has been a tremendous asset to us in Orange County and in Southern California, as well as in the state of California, in providing a great forum and a way by which the Mirage Business School participates in the healthcare of both the providing of and the study of healthcare in the state and in the community, if not nationally. And it is our privilege to be providing educational activities such as today's panel to provide for that continued education and continued engagement of many of us, many of those who are providing for the healthcare in our community. Let me say a bit about the format today. This will be a panel discussion, and obviously this is a different time. So we're doing this by Zoom, and that creates some opportunities to bring some tremendous capability and talent to our speaker panel. On the other hand, it also creates some challenges. So if you could have a little grace with all of us today, I'm sure that we have learned much on how to provide for and how to participate in conferences like this. We hope that everything goes off flawlessly. We know that things can happen. We hope that we have technologically and logistically a very, very good 90-minute session today. Our plan is to go from 9 to 10:45, and we will have presentations by each of the panelists moderated by Dr. King, who I will introduce in just a moment. And then we will have time at the end for a quite in-depth question and answer session. Related to questions and answers and comments, we'd like you to use the Q&A button on your function on your Zoom. I trust that each of you will know how to do that. We will monitor those questions and then we will convey them to Dr. King, who will then read the questions and maybe bring them together into common questions for the panelists as well as for discussion among the panelists. So please use the Q&A function for submitting any questions, answers, as well as comments that you would like to make. So with no further ado, I'd like to introduce our moderator. We are so fortunate to have Dr. Talmadge King with us today. Dr. King is the Dean of the School of Medicine and Vice Chancellor for Medical Affairs at the University of California, San Francisco. Dr. King is a member of the National Academy of Medicine, the American Academy of Arts and Sciences, and the Association of American Physicians, as well as the American Clinical and Climatological Association and the Fleischner Society. He is a master of the American College of Physicians and a fellow of the American College of Chest Physicians. Dr. King is past president of the American Thoracic Society and past secretary treasurer of the American Board of Internal Medicine. His credentials, his accomplishments, and his continued leadership in the field of medicine, not only internal medicine, but medicine overall has been of tremendous value, not only to the University of California, the state of California, but to this country. And so it's my pleasure to introduce and bring you our moderator, Dr. Talmadge King. Dr. King, please.
Thank you very much, Dr. Afable. These times have really changed us. And so I would like to start by just a somewhat eclectic review of where we are today from the perspective of the UC health system. So the University of California Health ecosystem has 18 professional schools, including dentistry, medicine, nursing, optometry, pharmacy, and public health. We have 15,000 students that are trainees. There are 6 health systems, 5 academic medical centers with 12 hospitals with more than 3,900 licensed beds. So we're the 4th largest healthcare delivery system in California with an operating revenue of about $13.4 billion. So this crisis has completely changed how we interact and work individually and collectively. I just want to share a few things that have happened at our institution that I think has changed us forever. In the clinical arena, we have 4 missions: clinical care, education, research, and public service. One of the major things that has happened is our rapid deployment of telehealth during this pandemic, with video visits, online remote second opinions, internal inpatient consultations, and consultations with outside facilities. We've been trying to implement this for years, and on March 15th, it looked like we turned on a dime, and everybody understood that this needed to happen, and we were able to make this really dramatic change. So that's one example in the clinical arena. Educationally, we shift completely almost to remote learning. And fortunately for us, our young learners are very adept at all of this, so they have adapted extremely well. I think the old fogies in the group, including myself, have had a little bit more struggle doing that, but we also see the value of this remote learning, and we've changed. We continued our medical school basically open, thinking that our medical students were actually essential workers, and they needed to learn from this pandemic. And so this is one of the things that's happened in our educational arena. In research, this also has been a major change in how we operate. And several things have been interesting. So for example, as COVID-19 pandemic has continued, we now know that there are more hospitalizations, higher severity, and higher mortality among men. And it's interesting that our researchers were able to jump right into that and figure out that androgens, male hormones, such as testosterone, appear to boost the virus's ability to get inside cells. And this is particularly true of men with male baldness, who tend to have higher levels of testosterone. So a group of researchers went through all of the catalog of drugs that are currently available and actually have identified a number of candidate drugs that may actually help treat the disease. And this was really a tour de force. Along the same lines in research, well, our teams have done things that we thought could not happen. For example, they have rapidly identified the building blocks for antiviral drugs in a very rapid study where a novel line of attack on coronavirus biology was identified through the collaboration of groups that hadn't worked this well together ever, including the QBI Institute at UCSF, Lawrence Berkeley National Laboratory, and the National Accelerator Laboratory, where they could crunch huge databases. So the collaboration reduced a 2-year timeline that was traditionally in place to actually 10 weeks to identifying this novel domain in the protein, in the virus, that we think will be attackable as the development of a treatment for the disease. So this is an example of how we didn't let this crisis go to waste. We've also at UCSF opened up resources to the community so that we can all work together on this, because we believe working together is the way we will defeat it. So we have an online resource that allows investigators to connect to others and to use resources that are being developed by others. We've also employed the community. So we have a COVID-19 citizen science study. This study is to help learn more about the virus, how it's spreading through the world. The goal is to enroll 1 million subjects from around the world. Any of you can join into this study if you like. Just text COVID to 41411 and you'll be connected, and then there's an app online that allows you to participate in the study. So we think that this kind of change in how we work is really important. In terms of public service, we have increased our partnership with the community. We have a community advisory board for research that we want to know from the community what they want, what questions they want answered. And we have found that sometimes their questions are different than what we think the questions should be, and those questions, answering them, we found are important. We've opened a Center for Community Engagement with COVID-19 resources, and this has also been helpful in getting the message out to our local community so that we can improve how we manage. Now, as a pulmonologist and critical care specialist, I feel I'd be remiss if I let this event go by without talking about the 3 W's. The first is wear a mask. Second W is wash your hands. And the third W is watch your distance. What we learned from history is that we learned nothing from history. 100 years ago, in the Berkeley Daily Gazette, this advertisement was put out during the influenza epidemic. That one of the most important things we can do to reduce the epidemic and the pandemic is to wear a mask. And it just defies logic that people feel that they can't or shouldn't. My view is that if you don't wear a mask, you have no respect for the people around you and yourself either, because this is one way that we can actually bend the curve of infection. You need to watch your distance, stay 6 feet or more from each other and not touch each other. And you need to wash your hands regularly, several times a day, soap and water, avoid touching your eyes and nose, and use other disinfectants to clean the area around you. I think with these are the things that are available. We have no treatment for this disease. So everybody has to be against this virus, and we have to do the things that we know work that will reduce the curve. So with that brief introduction, I'd like to actually now turn the podium over to our first speaker, who's Dr. Alice Chen. Dr. Chen is the Deputy Secretary of Policy and Planning and Director of Clinical Affairs for the California State Health and Human Services Agency. Dr. Chen.
Share my experiences and how COVID has played out at the state, what we've done in response, and reflect a bit about what's changed as a result, which really could be set up as everything. It's really hard to think about pre-COVID and not feel like it was a completely different era. Let me just see here. Great. You know, I joined the Newsome administration last September because it felt like it was a really unique opportunity to have a governor who was really interested in health, who wanted to do bold things, and in the context of a budget surplus. There was a real opportunity there to address issues, longstanding issues of coverage, access, affordability, and cost. And in fact, when you looked at the governor's January budget, there was a very broad health agenda there, including significant investments in Medi-Cal with more than $650 million in CalAIM, creation of an Office of Healthcare Affordability, generic drug manufacturing, and expanding. Can you guys hear me?
Yes, I can hear you.
Okay, great. I'm getting a message here that my speaker's not working. And expand Medi-Cal to undocumented seniors. And then COVID happened. And we really pivoted from this very broad and ambitious healthcare agenda to really a laser focus on addressing the pandemic. And when I reflect on the last 4 to 6 months, I really think of it as phases, like you go in this intense phase and then you kind of pivot as we adjust to the changing circumstances. And what I would say is the first phase started probably in late January when we had our first known case of COVID in Orange County until early March when we had our first, at that time, known death, although we know there were previous deaths from postmortem from COVID in the state's emergency order. And what I would say is from that group, okay, let me know if you can't hear me, someone just chat. Oops. If you can go back to the first slide. this was the appeal from, can you hear me? Okay.
Alice, I can hear you and I can see
All
you.
right. Okay, and I don't know what happened to the slides, but that's fine. So basically,
They're back on now.
okay, excellent. Just echo Rick's request for patience here. So that first phase really, I feel, I think of as pre-public. So the public health community and certain medical centers like UCSF Medical Center were pulled headlong into COVID. Everyone else was kind of tracking, but more or less it was life as normal. And then in mid-March with the stay-at-home orders, first in the Bay Area and then at the state, things radically changed. And I think that was really driven by a couple things. One is watching what was happening in Italy and New York, and then frankly, working with our modeling team. And remember, those were early days, data light times when we were really trying to figure out what might be the impact of NPIs, non-pharmaceutical interventions like staying at home, the things that Dr. King talked about. And some of our models are really dramatic and scary. They were showing that we might have an excess hospitalization peak of more than 10 times the number of beds we have in California. So that was really what prompted, the nation's first stay-at-home order and really round-the-clock planning for acute care surge. So we did a number of things, which you may or may not remember now, because again, COVID days are kind of like dog years. Each week feels like a month. But back then, we worked with the feds. We had the USS Mercy down in Southern California. We stood up federal medical stations across the state. We stood up the LA Surge Hospital, which was a Herculean effort on the partnership with Dignity and Kaiser, which was really an amazing effort. If you haven't read about it, standing up an acute care hospital essentially from scratch with a focus on critical care patients and ventilated patients being about 50% of the patients. Seton up here in Northern California, as well as a number of auditoriums and hotels as alternate care sites. And after all that work, what we found was that the stay-at-home order really worked and we really flattened the curve. And that was a pause point for us. And we really had to step back and think carefully about how do we start to reopen California, identified a number of indicators and capacities that we needed to have. For example, testing, contact tracing, protecting our most vulnerable, continuing to work with our hospitals to make sure there is sufficient capacity, tracking therapeutics, and most importantly, in some ways, creating the data infrastructure that gives you the data that you're seeing on the screen right now. And I hope for those of you who haven't been on the website, the state has a number of really rich data sources, and we're partnering with many people across the UC system to use this data to inform policy. So we created a roadmap with 4 stages. And I want to pause for a second just to emphasize a point that I think everyone knows but bears repeating. We knew at that time, and we know now, that before we have a vaccine or readily available curative therapeutics, as we start opening up, as we start moving and mixing, we will have more transmission, we will have more hospitalizations, and we will have more deaths. And our goal all along was to balance the harms from COVID infection and impact on the healthcare system with the harms of shutting down the economy and schools. And I think it bears reflecting that pre-COVID, California had one of the largest income and wealth disparities in the country. And shutting down the economy really impacts primarily and foremost those folks who are on the margins of our economy. And what we really want to avoid is protracted and deep poverty, particularly for our most vulnerable. Similarly with schools, we know that underserved kids and kids in lower economic households really feel the impact of any kind of delay in educational attainment. So that aside, we started putting out guidance based on sectors. And I think one of the challenges that bears noting when we talk about challenges of COVID is California. The size and the diversity of California makes it really difficult, makes it impossible to have a one size fits all. The geography, demographics, culture, density really precludes having a single policy that fits all sectors. If you go to the next slide. Thank you. And as you know, as we started opening up, as predicted, we started having more cases, particularly among younger people who are really, on the one hand, the good news is that they're much less likely to get seriously ill and die. On the other hand, they create a really large reservoir for the rest of society and are more vulnerable and at-risk people. But what you can see, and this is again on our website, is that as we open, we are monitoring each of our 58 counties very carefully. We have a number of measures we follow. And you can see that even now, there are many counties, particularly in the far north, where COVID just isn't having as big an impact. And so we talk about the fact that there isn't one pandemic in California, there are at least 5. There's the border with Imperial County, there's LA, there's the Bay Area, there's Central Valley, and then there's the far north. And again, it's really hard to fashion policies that are uniform and respect kind of the assets and challenges within each area. And I know that a lot of people, particularly recently, have been thinking that the patchwork nature of some of our modifications is confusing, and just want to emphasize why that is. So next slide. I'm sure all of you guys are well aware of the fact that over the last 3 to 4 weeks, we've had an increase in cases. We've had this gradual increase in cases for a while, but many of you probably also know that was in the context of increasing volume of testing, and our test positivity had remained stable. As cases rose over the last 3 to 4 months, our test positivity started to rise. Next slide. And importantly, our hospitalizations and ICU census started to rise. And as we followed this, and again, we follow this data religiously and every day, we started to take action. So June 18th, which is really about the, I can't move the cursor, but it's right where the curve starts to move up. We issued the mandatory face covering across the state for public places. On June 28th, we closed bars in high-risk counties. July 1st, in anticipation of 4th of July weekend, we closed certain indoor activities. And yesterday, we closed bars across the state and certain indoor activities statewide, and had additional modifications for the high-risk counties. And again, I really want to emphasize that what we're trying to do here is balance health and healthcare with economy and education. And we're trying to use the evidence to create what's essentially a new normal, where we do all the things that Dr. King was talking about. And the other thing we've learned is it's safer to take things outdoors. So that's the genesis of a lot of our current policy. Do things outside as much as possible, try to avoid mixing, wear your face coverings, practice physical distancing, keep up the hand hygiene. Those are the key things and messages that we need to send if we want to be able to actually loosen our restrictions again, which is absolutely our goal. In parallel, we're working with our counties and hospital partners to ensure that we have enough healthcare capacity in the healthcare system to care for patients. But make no mistake, our goal is to never have to have a surge to a crisis level of care. So as we make sure we have capacity in the healthcare system, we also need to be using the levers of our non-pharmaceutical interventions, the modifications, and if needed, a stay-at-home order again, although that's something that really is a last resort in order to make sure that the hospitals don't get overwhelmed. And then lastly, we're really thinking about how to better protect our most vulnerable, and that includes essential workers, people who live in congregate settings, including skilled nursing facilities, prisons, jails, shelters. We have an obligation as a society to really make sure that we create the both individual and environmental protections to keep these high-risk people from being infected and dying. So over the course of the last 6 months, I think it's fair to say that we've done a lot and we've learned a lot. We are far from perfect, but I think it is useful to touch on how far we've come. So, for example, I'll give you about 6 or 7 things. Testing went from an average of 2,000 tests a day at the end of March to more than 100,000 tests a day at the beginning of July. In terms of PPE, the state has procured and distributed tens of millions of N95, surgical masks, gowns, and gloves. We are working on our stockpile of ventilators. We developed the California Health Corps, which is a volunteer program of health professionals who can be hired by the state to be deployed. Many of them actually have been deployed to our skilled nursing facilities. We recognized early on that SNFs were a very high-risk group. Our SNF population at our last estimate accounts for less than 1% of the California population, about 44% of deaths. So we've had a laser focus on figuring out how do we support our SNFs to keep those residents safe. We've stood up the alternate care facilities that I mentioned before. While we have decommissioned the LA Surge Hospital, we still have Seton, we still have many of the other sites on warm status and ready to reactivate if we do have a surge. We've done a lot of work around therapeutics. We set up a whole convalescent plasma program where we leverage the state's database to encourage anyone who's had an infection with COVID, a laboratory confirmed infection, to go donate convalescent plasma. And we've been working with the feds since May to advocate for remdesivir. And we're now transitioning to the new process that they've put out with Gilead. And then lastly, the data dashboards that I showed, and again, would really encourage people to go on to the CDPH and the ca.gov websites to look at the data and follow it. Because part of the issue is because California is so large, we are counting on people in localities and regions to hold their communities accountable in concert with the policies that we put forth. I will just wrap up with a couple of things. By nature, I'm an optimist. I think we know a lot more about the virus. So even as we're looking at these numbers, I think we have a better sense of what to do. Remember that back in March, we had no sense of how effective or ineffective our NPIs would be. We do know a lot more about the virus, including importantly, asymptomatic transmission, the fact that being outdoors is much safer than being indoors. We know more about how to treat patients, not putting people on ventilators immediately. And at least we have a couple of tools in our therapeutic armamentarium now that have impacts on both mortality and length of stay. And what I would say is our mantra at the state is that we are constantly learning and adjusting. And we know that we're in it for the long haul. I'll just end with a few thoughts about some of the issues that COVID has really highlighted for the healthcare and healthcare delivery system. One, I think the issue of employer-based insurance in the context of an unemployment rate that was projected at one time to be 20 to 25%, which rivals the peak of the Great Depression, really calls into question how we ensure access for all Californians. I think secondly, it really underscores both the importance that we had expanded Medi-Cal as part of ACA and its critical importance going forward. Prior to COVID, nearly 1 in 3 Californians was covered by Medi-Cal, 13 million. It's going to likely go up to 15 million. Medi-Cal is going to be a core important program across our state. The third, I would say, would be the need to better integrate public health, population health, and healthcare. I think where the gaps are there is where we see problems for our patients and our communities. I think we need to address the tension in the role of the private and public sector, whether it's around testing or therapeutics or supplies. And then lastly, just touching on what Dr. King said earlier, accelerating changes in the delivery system that are long overdue. I have been involved in the past with many innovations in delivery systems, particularly around telehealth and e-consult. And what I would say is telehealth by itself, I would say is frankly a little bit of a shrug. It is definitely more efficient, a better use of resources, but I think we can go a lot further than that. I think home-based and less resource-intensive care, including hospital at home, home monitoring and management of chronic diseases, home dialysis. Those are the things that I think we really should be pushing forward on, that are both more patient-centered and more value add. So I'll stop there and look forward to the other panelists and discussion.
Thank you, Dr. Chen. We'll move now to our next presenter, Dr. Deborah Power, who is the Medical Director, Optum Care Medical Group and Physician Lead of the COVID Communications and Emergency Response Team. Dr. Power.
Thank you. Can everybody hear me? Hello?
We can hear you. It's very low, Deborah.
Okay, let me make sure I get my mic back up. And we can put my first slide up. Is that better?
I can hear you, but you're still low.
Hello? Okay, let's try this. Any better there?
No, we can see your screen.
All right. And we have our first slide. Okay. A little bit about our group for those who don't know. Optum Care Medical Group is 72 primary care physicians with 36 APCs. We're spread throughout the Orange County area. Actually, we have an office up in Long Beach, and we have 4 offices down in Vista in San Diego County. We have 6 endocrinologists that are employed and spread throughout the Orange County offices, and 1 OBGYN down in San Diego. And we came about in 2011. We merged to become the group that we are, and we've been evolving with putting together this group with different acquisitions. We were initially acquired by Optum, which for those who don't know is part of the United Healthcare Group. And then around that same time in 2011, the Monarch IPA system also became part of Optum. And just recently, as some might know, Healthcare Partners has also become Optum. So we are merging and emerging in the Orange County area to become quite a large group, and in the midst of COVID, trying to accommodate as many patients as we can in that ever-changing climate. So it's been pretty challenging, and I'd like to thank Dr. Chen for her guidance as the medical director for our group. We've been using those data dashboards daily to look at our area and the areas surrounding, so we can monitor our response and see what we need to be doing to improve, and look at different closures in different offices, or possibly, where we need to be making adjustments. So that has been really helpful for us. Next slide. I thought I'd walk everybody through sort of how we approached it from the primary care approach. And this was basically what we did. Starting early on in March, the leadership decided that we would follow the CDC guidelines. Our leadership is myself, another medical director, our president, and then we have the Greater Optum regional leadership, and we have a national leadership where we were having almost daily phone calls, and it's turned into weekly now. And we made just small adjustments in the beginning, like change our hold script, or what the call centers were doing for scripting and triage. And our doctors are pretty on point. They didn't want certain things coming into the offices that could be managed with phone calls. I led a daily WebEx for our providers and staff. We have over 300 staff that were very nervous about what was this and what was happening in the community. And at times we had over 200 people signing on to these WebEx. By mid-March, from National, our company decided that all high-risk providers and staff could self-identify to stay home and work from home. And we had to hurry up, huddle, and arrange for headsets and being able to work with laptops. Not all our staff had laptops at home or even decent Wi-Fi. So we had to arrange for a lot of people being able to pivot and work from home. The credentials for being able to work from home or being high risk at that point were identified as age greater than 60. Now it's age greater than 65. Any chronic diseases for self or even a household member, pregnancy. And then our parent company also provided a subsidy for childcare, because if you recall at that point, a lot of the in-home and public childcare was shutting down. Schools were closing. So our staff and a lot of the providers didn't have childcare, so they couldn't come to work. So there was a $100 a day stipend, and it could be paid to a family member if they weren't working, or even if they were working from home and could help you out. There was a $50 a day transportation stipend because some of the public transportation was available, but things that some of our staff felt safer in, like Uber or Lyft, still was available at that time. So we had to pivot for them to be able to get to work. March 19th, we were doing a pretty quick setup in collaboration with healthcare partners. And we thought this was the best way to preserve PPE rather than 26 individual offices trying to scramble and order PPE, and some doing a lot of testing, some didn't want to do testing on site. It made the staff nervous. So we have a central site down in Santa Ana off of Harbor that the docs can all order the test, but the patient is called. We have a system set up where they're given an appointment time, they drive up, they stay in their car, and then they're called in, they're swabbed. We're doing the anterior nasal swab, so they actually do a self-swab hand to back. It's been working really well. When we started, we were probably doing around 20 tests a day. Up until 2 weeks ago, we were doing about 100 tests a day. And then right now we're going through a shortage, which everybody is. So we've had to cut way back on that. And then by March 20th, we were doing daily temperature checks for all staff and providers, and trying to identify any staff that had called out for COVID-related disease. And we established an outreach team to monitor staff and providers that were sick, maybe COVID-related. Our group does not have employee health. I'm de facto employee health, and I have 2 other physician providers that help me with that to monitor, because we had always relied on people going to their PCP, but we realized they have to be able to come back to us, and we have to clear them to come back to work now. And then by March 24th, we had pivoted to telemedicine. At that point, it was telephonic. We identified 5 less impacted providers, a few APCs and a few physicians that we just blocked their whole morning and a couple hours in the afternoon. And we would just send all the COVID questions and block them into their schedule. We don't have a nurse line, so we thought that was the best way to handle all these questions coming through from patients. And it offloaded some of the providers that still were seeing patients in office. We were directing at that time, if there was a suspect patient with COVID, to start using PPE. And we were at that point thinking we were preparing for the surge. And then we have some really great physicians that do a lot of research, and we're starting to get nervous about different procedures we were doing in the office. So at that point, we had stopped doing nebulizer treatments. We thought that was not right in our setting. We don't have negative flow rooms in any of the offices, so we did stopped doing those. We stopped doing pulmonary function tests, and we stopped doing fit testing. So next slide. And then by early April, we decided our seniors were not coming in, and they were fearful, and we weren't actually even hearing from a lot of our patients. So some of our staff had a lot of downtime. So we made some decisions to do call outs to them. And we decided we would just do some social call outs and see if they were lonely, see if they had some food insecurity, if they needed their medications refilled or delivered. We had pharmacies that were doing deliveries. And anybody that hadn't been in the last 6 months or didn't have an upcoming appointment in 2 months, we ran some reports. And it was insurance blind. It wasn't just our IPA patients, it was all patients. So, and it was actually really well received. A lot of the people at that point, it was only a couple weeks in, but people were already pretty lonely. And coming up, I'll show you the script that the staff was using. By April 6th, we were using masks for everybody. And then we started doing some rotations in out of the office. For some of our offices, we actually just changed them to completely remote. And we only had one provider.
Tiffany, can you dial extension 1303, please?
That's how it goes here. We would only have one physician in the office at a time, and sometimes two in the bigger offices, and minimal staff. So we were just minimizing foot traffic. We were a little concerned about PPE and trying to preserve as much as possible, although we do get most of our PPE from a central source and a national source, and we were stockpiling. We just weren't sure about how many we would need, and again, we were still looking at potential surge at that point. By April 23rd, we had really pivoted to video training, and we were getting a lot of support from our national company, Optum, and this was the fastest we thought we would ever move on this. We've been begging for it for years, and as Dr. King said, you know, everybody had wanted this, and we really were pushing forward. And it was amazing how fast this was adopted. I would say the providers were the slowest link in some ways, and some of our more seasoned providers did move a little slower than the younger ones. By the end of April, we had screening questions that we have staff at every entrance. The entrances are mostly locked, or sometimes they're outside with a pop-up tent. And we do temperature screenings. Now they ask 9 questions for COVID symptoms before the patient can come in. All staff get screened with temperature checks and the same questions. We have banners that stand outside and floor signage that space out everybody 6 feet. Next slide. And this is sort of the workflow that we were working off of in the beginning. As you can see, there's a lot more detail that we added about which patients should come in for appointments. We moved a lot of appointments. We thought at that point we'd just move them out 2 or 3 months, and then everything would be fine, and this wave would be over. And here we are 2 or 3 months later, and now we have all these patients that we pushed their physical back. We pushed our new patients back. We're sort of dealing with that now, and I can catch up on how that. The ones that we needed to see in the office, we thought was any fever that didn't have the URI symptoms, cough, shortness of breath, any falls, any potential wounds, certain hospital follow-ups and pre-ops and things. At that point, pre-ops kind of fell off because patients weren't getting surgery, at least not elective surgery. So next slide. And this was the script that we used. Staff was calling and just saying, I want to make sure that you have everything you need. These were for our senior patients. And again, insurance blind. Do you have food? We have resources available. You can call us at any time. And then just making sure they had a 90-day supply of their medication, and checking to make sure we have their right contact phone numbers. And then next slide. This was also part of the script. We wanted to make sure coming up, we knew we were pivoting to televideo. We wanted to make sure if they had an email address, or did they have a smartphone or a tablet or desktop or a laptop, just knowing that we were getting that set up. And they were told they had to identify the patient and how they would close the call and all kinds of contact information. And some of this playbook came from some of our sister offices throughout the nation, Texas, Florida, Arizona. So we're all sharing information throughout the nation and best practices. And it was really an exciting collaborative time for us. Next slide. This is our Cypress office. We would do, in our weekly WebExes, we would share photos of what was working. It was a lot of good team building. This was their attempt at social distancing, and this was before everybody was wearing masks. So it's hard to see on the signs, but it basically says, please stay home. We are here to protect you. We are also, we will call you via telemed, is I think what it says in the yellow. And a great office. They really have taken on the team building and daily huddles. And even when they're not all in the office, a lot of the daily huddles are via Zoom. We do that a lot too. So next slide. These are some of the resources that we sent out to the providers and the staff, where they have food banks and different hotlines for not only seniors, but even our commercial and younger patients, delivery services, transportation, people who were starting to feel depressed and anxious, different community resources. Monarch IPA had their social work staff and pharmacy staff and different case management on call, and also reaching out to some of the more impacted patients that we knew probably weren't going to seek out services. So there was a lot of outreach to them, and we were getting a lot of good feedback that people were really happy about that. And when we did eventually pivot to tele-video, the feedback was that, you know, we're so glad that you were calling us. We're so glad that you reached out to us. So next slide. This is our Leisure World office. Just again, it was a team building, take pictures of your team with their masks, show us what you're doing, and a nice big office at Leisure World. Of course, in a senior community, it's interesting that patients at first, of course, didn't want to come in at all. Now we're hearing that a lot more do want to come in. We are going to be setting up a second test site at the Leisure World Clinic for COVID because a lot of the patients there have an issue with transportation, and it was harder for them to get to our central site down in Santa Ana. So next slide. And then these are just, you know, I'm sure everybody's seen these. These are the CDC guidance that we used for which patients should come into the office. And, you know, basically focused on tier 1 at the bottom, the low acuity treatment that could be considered mostly for telehealth or postponed services. And, you know, that was where we were sort of in, you know, March, April, even early May. And then next slide. As these were some of the signages that we have at the beginning. You know, if you traveled, if you have, you know, cough or fever, please stop, go back to your car, call us, and we'll triage and see how you're doing. And next slide. So May really focused on growth in telehealth, looking at different screenings and testing as the models developed, how we could expand our testing. Our providers have access to what's called the Optimal Care Forum. It's a newsletter that our national team puts out. It's peer-reviewed database. It looks at ongoing studies and literature. And it's been especially focused on COVID, and our providers seem
very excited about that. I review it and go over it with my weekly WebEx. And just to give you a little insight into where we were as far as cases, the providers report all their positive cases to me, and then I roll that up in a weekly spreadsheet. Prior to June 22nd, all of OCMG, our group, had 68 positive cases, and that's just from our own testing or outside reports. So if a patient calls or does a video visit and says, oh yeah, I went to an urgent care, I went to the ER, I was hospitalized, we still report that so that we keep track of our positives. So from March until June 22nd, we only had 68 known positive cases. Then, since then, we're now at a total of 182. So we know, we're seeing what the rest of the state is definitely seeing. And as far as how that's impacting our staff, we had, prior to June 22nd, 2 providers test positive and 2 staff. And since then, we've had an additional 7 staff test positive. All of them were exposed outside of the office. We have not had an exposure within the office. So something I'm very proud of, very happy about. We are having a lot of monitoring happening within the offices. We had last week up to 17 staff that we were monitoring for exposure at home. There was an exposure at work with another employee, but we haven't had a conversion, or just monitoring for COVID symptoms. And of course, we keep those patients home. We are looking forward to having something to help with our monitoring, looking to get the Protect Well app. I don't know if other people have heard about this, but it's a symptom monitoring app they can use on their smartphone to check their symptoms before they come to work. Also, they will monitor their temperature. So I'll take questions about that later if people have it. And as far as for July, we were working on re-expansion before all the numbers started going up, and we did start seeing some more patients in office, and we're still working on that, but we're really emphasizing telemedicine now. And as far as our central testing, we really had tried to expand. As I said, up until 2 weeks ago, we were up to 100 tests a day for our group. But now we're hearing from all the test sites, and I know everybody's seeing this in the county, that LabCorp, Quest have really slowed their process. So we're just not able to get the numbers that we need. So maybe we can take some questions on that. And then next slide. These were where we were. I just wanted to show, this is kind of a busy slide, but if you look to the far left, the blue are the in-office visits for our group. The orange is the telephonic visits, and the gray are the video visits. And as you move to the right, you can see that the orange has greatly diminished because we told them that you cannot do telephone visits after July 1st. And it has to be either video or in person. So you can see by July, it all became either in person or video. And our video has stayed pretty consistent. We're about half and half. So we're pretty pleased with how the providers are doing on that. And the patients seem to have quite a lot of satisfaction with it. And again, we see that it's really staff driven. They have to do a lot of education. A lot of the initial lift comes from them, training the patient, getting them on the video, getting them on Zoom, which for certain age groups is a little challenging, but not everybody, and they do well. And yeah, so it's been really good. And our volume is not what it was pre-COVID, nobody's is, but it's definitely getting back up. And then next slide. And then these are just some of the resources that we have for our providers through Optum and through our agencies. These are all free to them. They have emotional support line. There's a app, Sanvello, that's free to them, where it's guided imagery and coaching. And then if they do test positive for COVID, there's all kinds of resources. Their time off is not counted against their PTO. And then just other outside resources that they all have access to. So their satisfaction with our response has been extremely high. We did an employee survey in the middle of all this going on, and we got pretty much the highest numbers that we have. So we know that people are nervous, and the community is going through quite a lot, but we've been pretty happy in some ways that our group is coming together in a way that it wasn't before. And even though it's a very trying time, we're still working to close a lot of quality gaps. We want to get the students back. We miss having them. And the students need to come back into the office. And we're trying to figure out how to do that with, also being able to do telemedicine with them. We have scribes in the office, and we've still been able to even include them on the televideo visits. So I think there'd be a way to bring students into that as well. So we have different drive-through options coming up for our flu season. We're meeting to figure out how to do our flu clinics with the drive-through option, so we don't have to have patients coming through the office and going through a lot of PPE in that way. So I'll stop there and just wait and see when there's more questions. Thank you.
Tiffany, can you dial extension 1303, please?
So thank you very much, Dr. Power. So our next presenter will be Chad Lefteris, who's the CEO of UCI Health. So Dr. Lefteris.
Good morning. Hopefully you can hear me okay.
Yes.
Great, thank you. Thank you, Elisa, for the slide. So I just wanted to start by thanking my panelists and colleagues before me, because I think what we're hearing from them is a direct result in why maybe Orange County is doing so well, and why California has done well, and I know we'll continue to thrive as we get through this surge together. So I feel very fortunate to be a part of this, so thank you very much for including me. My name is Chad Lefteris. I'm the relatively new Chief Executive Officer here at UCI Health, and I had the good fortune to join this team as the Chief Operating Officer just about a year and a half ago. And I think I'm still the only person I know of who took over leadership of a health enterprise during what I think is the equivalent of the 1918 Spanish flu, the 2007 Great Recession, and the 1960s social justice protests and demonstrations, all happening at the same time. So I'm not sure if I have good timing or bad timing, but I do love a challenge, and it is my pleasure to share with you a few things about what we are doing in light of what's happened in the last few months. So next slide, please. So a little bit about us briefly, and I have to start by thanking the nearly 7,000 teammates who ran into this fight way back early in this springtime before we really even knew what it was. And I am just so proud and grateful for what each of them are doing every day, every night, 24/7 to care for this community and for our patients and their loved ones. So, I won't go into much detail about all we've done leading up to this clinically, but just as a reminder, you're in very good hands here with this team. I would like to just remind us that as an academic medical center here in the county, we are built for this exact thing. I've been saying that a lot, that we are built and we plan and we drill for these sorts of surges and pandemics. And so we feel very confident about our plans to handle that as we go forward. I could spend hours just on that topic, but I'll move on and also just highlight one of the photos here. You can see the face shields that are being held there in the photo. Very early on, we started to hear about supply chain lines getting really hampered. We turned to our colleagues down on the main campus, and this is, again, the partnership with the main campus at UCI, where they very quickly created 3D printed masks and shields. And we were able to not only use those and put those into production quickly here, but share them with many of our provider colleagues around the county as well. So just one example of how we very quickly reacted and partnered with our colleagues on campus to really leverage that expertise. So next slide, please. So this morning I'm going to run through these very quickly, these four areas, give you some context for the financial impact across health systems within California, because I think that's important for context. How we are planning sort of now and beyond within UCI Health Enterprise. Briefly, how our plans for expansion in the Irvine-Newport area fit into this. And then what's life look like after COVID, if there is such thing. Next slide, please. So here's a snapshot of sort of the financial and volume impact to California hospitals and health systems. And actually, it mimics exactly our experience. If you look there in the bar chart, it shows that discharges were down around 35%. In our case, it was 32%, very, very close. ED visits were down across the state by around 62% when we told people to stay home, stay away, don't come to the hospital unless you're very, very ill. Our ED visits didn't drop by 60%, it's about 47% for us. But again, this is an average across the entire state. As you can see at the very bottom, those boxes talk about the amount of revenue that was lost because of those lack of volumes and patients choosing not to come in and elective surgeries and other things being put on hold, appropriately so at the time. But that's a big revenue impact. So you can see, if you look over there to the bottom right-hand side, about a $17 billion revenue impact for all of the health systems across the state is expected through April or spring of next year. The good news is, thanks to the CARES Act funding, there's been real money sent to Safety Net and other providers. The bad news is, you can see it's only a few $1 billion, and I hate to say it like that, but in reality, that's only really filling the bucket up partially to make up for the difference. So all of the providers were grateful for our colleagues in Washington and elsewhere who have helped make that happen, but we still have a long way to go as we stare down this sort of unknown future before us. So next slide, please. So what are we doing here? And I want to really start by saying that we're not going to let a good crisis go to waste here. And I think we've been leveraging that as much as possible. You know, academic medical centers across the country are known for a lot of wonderful things, but we're also known for being a little bit slow to move because we're bigger in some ways. And I will just submit to this group that I've been so pleased that this academic medical center has pivoted so quickly, turned on a dime for many, many things as we've been through this process. And that will not stop post-COVID. We're learning from lots of things that we're doing during this trying time, and again, leveraging that as we go forward. As you can see in the background here, there what looks like a weather map, and that's not the weather. In fact, that's if I could play it live, and you would show it kind of changing color over time, and it's one of many models that we're tracking. And this shows really the number of positive cases of COVID-19 throughout our county, and you can see what should be bright red or purple there, really for the Santa Ana and Garden Grove and Anaheim areas, something we're tracking very, very closely on an hourly basis. I want to thank Dr. Dan Chow and his team for creating this tool. Again, one of many models that we're working with to make sure that we're staying ahead of the curve as much as possible so we can be prepared for whatever is coming next. There it talks about capitalizing on workforce and financial sustainability. Those go hand in hand. We already talked about the financial impact to health systems across really the state, but also the country. So we are working very closely with our teammates here to redesign the work and care to make sure that we can be as well positioned financially for the unknown as we go forward. And overall, trying to look at how we reduce the cost of care and do so in other interesting ways, whether that be care in the home, which I'll talk a little bit more about. We are committed to maintaining our workforce that we have in place here. While many other health systems are being forced to unfortunately furlough and lay off staff members, we are not doing that. We have no plans to do that. And we're going to work to really repurpose workforce. We've already done some of that as volume has shifted, and volume has now really surged back, both on the COVID-19 patient side, but also on all other patient side. We saw the makings of the next public health crisis, which was so many people were delaying their necessary care because we told them to stay away. So we've seen a real resurgence of that volume as well. And so we're making sure that we capitalize our workforce to handle that volume. I think we could spend our entire time really on the health disparities question. And Dr. Chen, thank you. You brought that up nicely at the start of your discussion. And I really think this needs a lot more work. But in my opinion, the COVID-19 pandemic has really served as a bit of a mirror as well as a magnifying glass, reminding us really of the inequity and disproportionate care that takes place across the U.S. health system. And a report from the CDC back in June found that both Black and Latino Americans with coronavirus have been hospitalized as a rate nearly 5 times greater of white people, and Native Americans at a rate of 6 times greater. So we have now data that just supports that we have more work to do. A colleague back on the East Coast, the CEO of one of the largest health systems there in the Southeast, recently made a wonderful statement about sort of all this. And I'll just quote him because I think it's powerful, which is, someday soon we'll have a vaccine, and we've already talked briefly about that. But that's for COVID. There's not a vaccine that we know of for racism. We've got to do more as organizations, as individuals, and me in this role, and partnering with Dr. Stamos, the Dean of School of Medicine, we are doing our best to improve that fact. And finally, on the strategic collaboration side, I feel like this is one of the good things because of COVID, that I truly believe that health systems have already partnered and will continue to partner differently than maybe we have before. We're already breaking down walls between what folks who might have just been competing as we work together to manage this health crisis. And I think that is the wave of the future, whether that's just for UCI Health or others. But that is certainly the way that my team and I will be approaching our next steps in the future. Next slide, please. So briefly, as we think about questions that I get all the time, one of them is, Chad, are you really still planning your expansion plans within the Irvine-Newport area? And the answer is absolutely yes. We actually need these beds today, and it will help us for the next pandemic and the next pandemic. And so just briefly, this site is located at the corner of Jamboree and Campus, right where Irvine and Newport come together. Off to the far right-hand side is the rest of the main UCI campus. So the proximity will allow us to leverage even more so than we can here in Orange. And just looking at that timeline, you can see that we already received approval from our University of California Regents for the first phase, which is the Center for Child Health and Adult Care that will open in late 22. We will receive final approval for the inpatient side of that campus, the hospital and ambulatory care center. We will go in January for that final approval, and we fully expect that to occur. So full speed ahead. We're in full-blown design for both of these 2 phases of the projects, and really taking a moment right now to stop, pause, and learn from what has happened throughout this COVID-19 period. Yes, there's a lot of positives to take away as you will design spaces differently, and also how we leverage technology differently in these new spaces. So it's actually wonderful timing to be able to stop for a moment and really retool our design efforts to be as proactive as possible. For example, we're going to design that entire hospital to be acuity adaptable so that as we need more ICU beds, which Dr. Chin noted earlier, we can very easily flex those up without a lot of work. So a lot of good things happening for us there in the Irvine-Newport location, but I won't go into much more detail today, but just know that we are still full speed ahead and pending the final regential sign off for the inpatient side of that campus. Next slide, please. And finally, as we look to the future and reimagine a little bit about what life will be like post-COVID, if there is such a thing. And we think about perhaps there is an opportunity as we plan for the next pandemic, whatever that may be. As I said, as the Academic Medical Center in Orange County, we are built for this. We will continue to refine our planning efforts and drills and other things to make sure that we take all the learnings from this pandemic and pull forward. We will continue to partner with our public health colleagues in UCI campus. They're doing a ton of work with us and around the community, and that's a wonderful resource that, again, the broader UCI can bring for this community. We'll continue to work to manage this population differently, again, by what we've learned through this pandemic, but beyond, and that's something that you never really will stop doing, in my opinion. So we're going to continue to focus on that and partner with Orange County Healthcare Agency and others to do so. Dr. King already mentioned the digital transformation and telehealth, and to be quite honest, I look forward to not calling it telehealth anymore, Dr. King, and what I mean by that is we don't call it telebanking anymore. We just call it banking online. It's what we do online, and so for me, telehealth will very soon become just another very important interaction our providers get to have with our patients, whether it's in person or via one of these platforms like Zoom. And it just becomes another necessary thing that we do to keep our patients well. And then also mentioned by Dr. Chin, we're spending an awful lot of time on moving care out of the four walls of the hospital or the clinic setting and getting it into the patients and families' homes. I think that is so important for a lot of reasons, but not just because of the pandemic and we keep people safer at home, but as we think about the future and where we're heading, the technology advances that are happening there, we're on the forefront of that, and we're going to continue to leverage that as we go forward. So more to come on that. But as the patient, this is what I want. Like, I don't want to have to go get in my car, drive, travel, go to a clinic visit, risk infection perhaps if the pandemic is still happening. And if I can get everything I need at home, how wonderful is that? So I think we will continue to work that as we go forward. And then really finally, back on sort of what I call the power of the broader UCI. Luckily, we get to leverage that power as just one component as the health enterprise here at UCI Health. And we, as I mentioned earlier with the face shields, so many other innovative examples where we get to take really advantage of the brain power, the innovation and entrepreneurial spirit that exists on the main campus, as well as the research and discovery that's happening there, and really bring that forward to our patients and families. And that's something that doesn't stop. And we will continue to press the gas pedal on that as we go forward, because it will influence each of these as we move ahead throughout and beyond this pandemic. So again, just hopefully that gives you a snapshot of how we're spending our time, both in this sort of response and recovery phase. And I could go into a lot more details about our response, but really today it's about recovery and reimagining. And hopefully you see this is sort of our direction as we go forward and really leveraging the power of the broader UCI. So with that, I'll be happy to go to the next slide and then stand for questions. Thank you so much for having me here today.
So thank you very much, Dr. Harris and the other presenters. We now are in a position to sort of answer any questions that people have. I guess I'd like to start with the presenters. Any of you want to have an additional comment or thought that you'd like to present before we sort of open it up? Dr. Fable, what about you? Anything that you want to?
Well, thank you, Dr. King. I would just add that the insights and the experiences of the panelists are so rich as we weave a bit of a fabric, because they all three of them coming from a different point of view, dealing with, all four of you really dealing with the same issue, the relative same issue, but a different point of view, and having such an impactful way to be able to be thoughtful about the different elements, whether it be a medical group or a hospital or the state of California or a medical school. So thank you for that. That would be the comment that I would make.
Anybody else?
I just wanted to say, we're looking at, people are mentioning bringing the care into the home. One of the pilots that we're looking at is actually delivering tablets to people who don't have access to a computer or a smartphone. And it's interesting, some are very receptive and, it's white glove, we take it, mask right to their door, and it's already preloaded with our EHR and software, so all they have to do is press a button, almost like FaceTime. But others are they still don't want anybody to come to their home. They're still that afraid of an outsider or somebody bringing potential disease. So we're still sort of struggling with what's the right tempo of getting care into the home.
Yeah. Alice, you're on mute.
Excellent. Just a couple thoughts from hearing the panelists. I will say one of the silver linings from this pandemic is really just seeing people really step up. I think so many health systems and medical groups and people across the medical and healthcare community have really just jumped in the face of uncertainty, really done the right thing for patients and for their staff. The fact that, Dr. Power was saying her staff satisfaction scores were higher than ever is really a testament to probably clear communication and clear direction. That's really hard in an era of ambiguity when we don't know all the facts and it's evolving. I think the other thing I just want to underscore is the points around disparities, like even as we look forward to the leveraging technology, I mean, we can't forget the digital divide, the language barriers that really are impeding even some of our basic contact tracing for Latinx communities, the mistrust, the not having a vaccine for racism, really worried about when we do have an effective vaccine, how do we engage all of our communities to be receptive to it in a way that doesn't feel heavy-handed and tap into some of the historical mistrust. So there's so many rich things here that I think deserve ongoing work and discussion.
Yeah, I'd like to come back to your comment about vaccines, Dr. Chen. But first I want to, one of the thoughts that I'm concerned about is Dr. Power's in your comment about the employee satisfaction. So we entered this pandemic with some of the worst burnout among providers that we have ever seen. And I'm wondering what people are thinking about and how we're managing that problem right now, because this is, as Chad mentioned, this is a crisis within a crisis within a crisis, and it's really a difficult time. So, Deborah, you talked about some resources that you all have put together. I wonder how others are thinking about supporting the healthcare providers and the staff and everybody during this critical time.
Hey, Dr. King, this is Chad. I'll just start by saying we're probably spending more time on that than we are on anything right now. As you can imagine, as I mentioned, with almost 7,000 coworkers, there's community spread that we're trying to limit that here within our own community. We're a bit like a cruise ship, right? When we're here at work, we're all together, and while we're excellent at caring for our patients and donning and doffing our PPE, and then we might turn and forget for a moment as we walk into a break room. Well, we've changed break rooms and blown them out and made them much larger so that you can safely do that and not risk transmission. But burnout is a real thing, as you said before this. We are doing our best. We have brought in tons of resources, much like Deborah mentioned, around supporting our coworkers and workforce, whether that be childcare resources that we started early on, both in Irvine and up here in Orange, as those essential workers needed that support. We've also done a lot of other work through our Susan Samueli Integrative Health Institute that brought those integrative health providers to our caregivers to give them various forums and feedback and sessions to allow for them to decompress. Again, leveraging the power of UCI in a crisis like this. I feel like we've done a lot. You cannot do too much in this effort. We're gonna keep investing in our coworkers and our physician colleagues because this is a marathon and not a sprint. So I appreciate you bringing it up, Dr. King. It's hugely important, and it's one of the biggest concerns I have as we go forward.
Yeah. Any other comments about that?
The one comment, and I think both Chad and Deborah mentioned this earlier, but the issue of infections within healthcare workers is a real, is layered on top of the burnout and kind of stress of, particularly in the areas where we are seeing surges. We at the state are having a difficult time honing in, given the granularity of the data, differentiating between community acquired infection and occupational infection. What we hear from most of the hospital systems is when the contact tracing is done, it's very, very rarely an occupational exposure. We would love to be able to quantify that more, and so look forward to conversations with all of your systems and groups to figure out how to do that.
Yeah. So there are several questions. I'm going to try to organize them. One question relates to wearing masks, and the specific question is about face shields versus masks. I guess I would start by saying that we have to be careful about recommending face shields. Dr. Lefteris showed the ones that were developed at UC Irvine. To me, healthcare providers, and I have used them a lot as a pulmonologist working in ICU, as much to protect my eyes as anything. But they don't actually replace using a mask. The mask is sort of the best thing that we have, and the rigid plastic head shield, face shield, can be a supplement to that, particularly for people, hygienists and people, technologists and nurses working in real close contact with someone who may, there may be aerosolized products, but I don't think that the public should actually look to face shields as an alternative to masks. The masks are probably the best option. I wonder if anyone else has any comments or thoughts about that.
Yeah, I would agree. Definitely, we have staff that ask me if they can take their mask off if they have their shield on. And it's not either or. It's either mask and shield or just mask. So we try to preserve the shield for the providers that are doing an invasive procedure or something where they might get exposed with the shield is really to protect the eyes, as Dr. King said.
Yeah, and you can breathe around the shield, and you have this real, you can't help yourself, but you touch your eyes with the shield. And so, it's not as protective as people would think. So it's the mask, I think, that would work.
Can I ask, though, that this is where, certainly for healthcare settings, nothing replaces the mask. And then, in addition to eye protection, whether it's goggles or a face shield, but this is a place where I think, again, turning to the UC system and our academic partners, really trying to see for the general public, particularly in the setting of schools, whether face shields might be, what the relative benefit of that compared to a face covering or a surgical mask, because particularly in elementary and smaller, younger kids, the question has come up, if it's really hard for kids to wear a mask, would it be a reasonable alternative? And the data just isn't there. We can't say. Clearly, it doesn't protect you from inhaling. But the question is, epidemiologically, would it be a next best option?
Yeah. I guess I'm worried about that, Dr. Shin, because when I have worn them, they're uncomfortable. They're much more uncomfortable than people think. And you have this tendency to touch things that you don't want to touch, right? And so I think once people start using the mask and get used to it, and their glasses don't fog up, and they figure out how to use it, and they have access to changing masks when they get soiled. I think the kids are so adaptable. I think if we figured out how to fit them right, that they will do it. I mean, certainly, if you have nothing else, that's better than nothing. So having them around for having them use it, but I think that will help. One of the other questions we were asked is, several questions relate to telehealth. One of them is, how will that change chronic care management, you think, going forward? And a related question is getting paid for it. Will that change, and how will that affect what we do? Chad, I'll start with you.
Yeah, I think, thank you, Dr. King. I think one of the reasons there was such a rapid adoption of virtual visits and telehealth so quickly, there were really two reasons, right? One was we told people to stay away, and two was because there was reimbursement changes. And so I think hopefully that change will continue and stick. Here our experience has been, we went from 500 virtual visits a week maybe to 5,000 in just a few weeks. Rapid, thanks to our great IT and technology teams. And now we're kind of back down, averaging around 3,000 to 4,000 visits per week. And it's about 20% or so of our total volume. And I think, Dr. King, that's consistent with what I think some of the other UCs are reporting.
Yeah.
So I don't think it's going to go away. It will be interesting to see how the reimbursement changes going forward. As you know, that's going to impact it up or down. So I'm curious to see what others are experiencing or what others have heard that's out there in planning. But right now, I'm treating it like it's here to stay.
I would add that to Chad's comments that I think that chronic disease management using smart devices linked to registries and population and panel health managers is absolutely the way we need to go. And in terms of how it gets paid for, I think it really, my bias is that it needs to be not on a fee-for-service basis, because honestly, how do you bill for a uploading and reviewing of glucometer checks or weight for someone with CHF? I mean, I'll say that I just went back to clinic for the first time in 4.5 months last Friday, and it is really hard to take care of elderly internal medicine patients without their vital signs and without their blood sugar and without their weight. And so I really think leveraging technology in a way that's not just about the visit, but all the ancillary data, and then having it be proactive and not reactive, having somebody kind of monitor the people and reaching out and engaging them before they have a problem is really the promise of this kind of telehealth.
Yeah, I would agree. We're finding that people don't have scales, they don't have blood pressure cuffs, they couldn't get thermometers
for a long time, but getting those tools to them and is helpful.
That's a good extension 1306, please.
In a fee for value setting, that's the way to do it. Get our teams out there. We can send people to them to do that monitoring and utilize myself in a better way to see more patients quickly, or even in a group setting, our endocrinologists are doing their
it's 10:30.
Doing their diabetes education classes on Zoom, and then they can see large groups and do all kinds of teaching, and it's been very well received. So sorry, I know my volume's going down again, but we've been really trying to leverage the telemedicine visit so that we get more to greater populations and do more case management in that way.
Yeah. Another question, changing topic a little bit, is how do you see hospital procedure volume evolving over time? I'm sure, Chad, you've been thinking a lot about this.
Yeah, every day, as I'm sure your colleagues up in the Bay Area are as well. It's been interesting to watch how the ebb and flow of that has occurred since really mid-March through, as I mentioned, what I felt to be the start of a bit of a sub-pandemic or community health crisis around folks prolonging care that they needed. And while we haven't published anything on this yet, in our emergency department, we're seeing people, those that were coming in so much sicker because they had delayed their care, Dr. King, and I'm sure you've experienced the same. And so then what we've seen is a bit of a resurgence, if you will, a step up and plateau in that volume as we try and work that number down, get folks caught up for whatever procedural, medical procedure or surgical procedure they may need. And now we're projecting to see what will happen on the backside of that. At the same time, our community rates are surging from a COVID perspective. And so it's the intersection of that makes me most nervous. Last week, many days, we were running 120+% of our pre-COVID levels to try and catch up and get those patients seen. And because that's our duty, and we want to make sure we do that as efficiently and safely as possible. So we have a team of folks that are working within the procedural areas to really plan for the ups and downs of this as we go forward. I think we've proven, not just here, but at other provider organizations, that we can turn off that volume pretty quickly. But it actually takes a long time to turn it back on. It's not as easy to just turn that knob back on. And so we have come up with very nice detailed plans that allow us to slowly turn that down, the volume down as needed to, for whatever reason, and then to, again, slowly ratchet it back up in a safe manner. So we'll continue to refresh those plans as we go forward. I wish I could predict the exact points in which those would come up and down, but if I could do that, I'd probably be somewhere else. You know, I think that's our challenge, though, is making sure that our plans are solid and in place based on the learnings that we've had so far, and then we can hopefully flex as needed going forward.
Chad, could I ask, just to be sure that I heard what you said correctly, while you will go up and down, you're not expecting to shut down elective surgical procedures as you did back 2 months ago. So that would not be in the plans unless you were required to do so. Is that fair?
Yeah, that's a great point. And my answer may change if requirements change, but right now we have such a backlog of patients who prolong care. I have a real hard time saying, no, we can't see you, right? Because that's gonna, in many cases, worsen that patient's outcome. And so we are doing our level best right now to make sure we can accommodate all of those patients with no plans to turn that off, as you mentioned, Dr. Fable. However, we are monitoring it every day, actually several times a day, because it has lots of different influencing factors. The availability of PPE, for example, right? And so we track that very closely and making sure that we're not going to put anyone at risk by doing so. So right now, no plans to turn that off, but we do have a very, very solid detailed plan that allows us to step down if needed versus just throwing the switch completely off, like pretty much was happening around the country in mid-March. So hopefully that answers your question in a bit more detail.
Yeah, I just want to add that, you know, for us at UCSF, we're planning basically have a very similar plan. And I want to remind people is on March 15th, when all of this really sort of started in terms of our response to the pandemic as it was evolving, we weren't ready. And we are readier now than we were then. As Dr. Chen noted, we've gotten in place a number of things that will allow us the kind of flexibility that Dr. Lateras is saying. And we didn't have it at the beginning. We were so afraid of running out of PPE. And, you know, we just didn't have the resources. But I think as we have worked, certainly here in California, to put ourselves in a better position, we still have some bottlenecks in some parts of the PPE chain that we have to overcome. But it seems like now we have a much better understanding of what we have and what we need, and people understand how to use it, and people are not hoarding things. And so I think we've educated ourselves, and so we can manage this better. It's interesting. It's easy to shut things down, not easy, but it is really hard to open it up again. And so in this recovery phase, we're learning the difficulty of opening it up again. Let's switch to treatment. So there are a couple of questions about vaccines. So what's the best guess of when we'll have a vaccine for California residents? You know, particularly, I guess, in Orange County.
I'll tell you what I heard this morning, which was, you know, I think there are some companies who have already started mass producing risky out ahead, thanks to federal government support. There are at least 2 vaccines that are showing great promise. Dr. Chen and others may know much more. And so we're hopeful that something might be available for healthcare workers in early 21. What do you think, Dr. Chen? Is that too aggressive?
You know, I think this is the same response that you said. If I knew that, I'd be somewhere else. I mean, I have to say, you know, that it's always, we're hopeful, right? I mean, there's so many. I think the one, you know, observation I'd make is there has never been a time when there's been such a singular focus on one disease. And so just the multiplicity of efforts, the fact that we already have 2 vaccines in phase 3 trials, it's like, it's very promising, but I think also for talking to the experts, there's a lot that can go awry. So, you know, fingers crossed, but I don't know that we would plan on that. I think at the state, we are really looking at this for at least the next, certainly 6 to 12 months and potentially longer. So a lot of it really is around socializing the fact that these different ways of being, you know, the 3 W's, the taking outside, working with our health systems to responsibly titrate up and down procedures and deferred care, all of that is not a short-term endeavor.
Agreed.
I guess my take on it is that that we are in a remarkably different place scientifically than we ever have been. I mean, the example I showed of the collaborations with at UCSF with the national labs, and so we moved that needle dramatically to get the molecule, the structure, understand so much about the virus so quickly is unparalleled. So we've already chopped off a huge part of the timeline. But having done this now multiple times in my career, if we short circuit the process for testing the virus, we always suffer. And so we have to, I think what we have to do is fail fast, basically. And so one of the things is find what we have and put it out there in fairly large numbers. It's very risky, but we'll know very quickly. And that kind of collaboration and availability across the country, that's unparalleled. So it gives me hope that we can speed it up. And if it doesn't work, we'll know quickly and we can move to the next thing and not take, you know, the usual 10 years to get to something. But we've already, you know, chopped off a huge part of the time just by the huge collaborations that are going on really worldwide by different scientists. And we need to do that same thing on the clinical side with a lot of the clinicians working with each other to study this in the right way, so we get the fastest, best answer we can get. And I think it does give us an opportunity to have a vaccine by next year, and we'll just have to see. But that's really pie in the sky, and we have to be careful. One of the other things that came up was about testing and what we're doing with testing. And Dr. Power, there were some specific questions about how you all are testing, and you mentioned that you're having some trouble with the labs, Quest and that sort of thing. Can you elaborate on?
Yeah, sure. So
We are hearing from our local labs that they are really impacted. Their response has been that they're not delivering as many kits to our central site.
So Deborah, your sound is going down. Turn off your video and see if your sound works better.
Okay, try that. So is that better?
Yeah, that's better.
Okay, good idea. So what we're hearing from our sites is that LabCorp in particular is our go-to lab, and that they have really slowed their processing. We used to get our turnaround in about 2 to 3 days for our results. Now it's 7 to 10 days for results, which is almost sort of worthless when it comes to contact tracing. And basically their process now is they're delivering less test kits to us, which is there was a Wall Street Journal article that basically said that's their process now, and that will greatly reduce their ability to test. So it's becoming an issue throughout Orange County, and I don't know if the hospitals are seeing it. Probably not. They're prioritizing hospital testing, but the county agencies, OptumServe, which does a lot of the county testing, and our central site and the CVS sites are all booked out about 2 weeks.
Yeah, that's difficult. Chad, you had any thoughts about that?
Yeah, thank you, Dr. King. You know, this is an example where I think we've, across the University of California, 6 medical centers have been able to do what I call the Costco effect and really try and control as much as we can some of those supply lines from those major lab providers. Here at UCI, I will tell you some of the unsung heroes of this pandemic are our experts in our laboratory. And as soon as I'm able to hug them, I want to do that because they have been working tirelessly to get new platforms and new ability to test. We're now up to being able to test 1,000 today, 1,000 per day, and turnaround time is hours, not days, because I think Dr. Poirier just mentioned the importance, or really the lack, when you take so long to get test results back, not to mention the drain on PPE and other things. So it just has a pulling the thread and a ripple effect there. We will be up to 2,000 tests per day here shortly, and the plan is by the end of August to be able to do 3,000 tests per day within our own lab here in Orange at UCI Health. And that's because we've diversified across multiple different platforms, not relying on any single one supplier, because that was and is the issue for so many because they are taxed from a supply line perspective. So we feel very good about that, and we'll continue to monitor that every single moment of the day.
Yeah, so I think we've exhausted our time or close to it. So Dr. Pablo, will you give us some closing remarks and thoughts?
Yeah, thank you very much, Dr. King. And on behalf of the center, I want to thank our panelists. This was a, a terrific discussion. We do have many additional questions that we'd like to try to answer for you as well. I know that some of the attendees would like to reach out to the center and the Mirage School. So I do want to give you a reference for you. Diane Ford is our Associate Director of the Center for Healthcare Management and Policy, and she's available to you for attendees. And you can reach her at FordDM at uci.edu. FordDM@uci.edu, and Diane would be happy to put you in touch with one of the panelists to assist with answering questions that you might have related to the center. And again, thank you very much, panelists, for your willingness to spend this time with us today. Very informative, very helpful. I think what you've done, though, is created more questions for all of us, more questions that need to be answered, because I like to say we're in the fourth inning of this thing. We've gone through the lineup. Everybody, all the hitters have seen the pitcher once, and now we're going to play the remaining 6 innings to figure out how exactly this is all going to play out, and how the game can be concluded, all for the benefit of our communities. I did want to mention that the center will and is planning to have its 30th annual forecast conference next February 18th and 19th. Those are the tentative dates for the conference that has been going on now for 29 years, and we hope to have it in our 30th annual. We also hope that it'll be in person at the Beckman Center here in Irvine. We'll see. But if it can't be done in person, we certainly will do something very similar to what we've just done, and it will be a very robust and important conference attended by hundreds of individuals every year, and our compliments to the leadership that has been putting on that forecast conference. 2 other things that I wanted to mention. We have a certificate program in leadership and healthcare transformation that is being provided by the Mirage School and its adult education, ongoing continuing education department. And so I refer that to any of you that might be interested in a certificate program. It's typically a 4-month program in the winter semester, if you will, right after the first of the year. Very, very good and helpful. I participated in it for 4 or 5 years, and I would offer that to anyone who would be interested in a non-degree program, but a very in-depth leadership development for healthcare. And then we can't help but talk about the MBA program, where healthcare is one of the pillars of education for our MBA program at UCI, and that is available. And many of the people who are attending this conference today are MBA graduates from UCI, and specifically in the healthcare track. So I just wanted to be sure that that you all were aware that that was available. And so with that, I did want to make one last comment for those who are still on this conference call, and acknowledge the passing of Dwayne Downer yesterday. Dwayne Downer was the president of the California Hospital Association for 37 years. And he suffered a sudden and an unexpected death yesterday. And I wanted to just acknowledge him as a friend and colleague. Many of you may not be aware that Dwayne Downer passed, but he did yesterday. You will be hearing more about that. He was an icon, a leader, colleague, and friend, and we will miss Dwayne very, very much. He spoke at the annual forecast conference four times over the last 30 years, and always honored us with his presence and amazed us with his content and his understanding of healthcare, not only in California, but also nationally. So I did want to acknowledge Dwayne. So with that, and by the way, Dwayne was such a great leader. This is not a downer for the end of our conference, but rather a celebration of a tremendous leader and a tremendous colleague and friend. So with that, I'm going to wish everyone a good day, and thank you for all attending today on behalf of the center, and a good day for everyone. Panelists, thank you very much. We are adjourned.